Thank you, Assemblywoman. Page 8, Lifelong Community Clinic, Urgent Care. It's the Assembly this time that has the proposal. Mr. Sue, you look like you have it at your fingertips.
Indeed, Mr. Chair. The Assembly has proposed approving one-time funding to Lifelong Community Clinic in West Contra Costa Healthcare District to provide $2 million to keep the urgent care open for 12 hours per day, which would capture up to 80% of former users at Doctors Medical Center, which recently closed.
I know the closure has been a great hit to the community. It's tragic in its impact. The question we have to ask, and if you can help us at all with an answer, is there any precedent for state funding for situations like this?
In the context of healthcare facilities, no, based on a review, we are not aware of any prior instances. The $3 million one-time appropriation to Doctors Medical Center in last year's budget was from a special fund, not the general fund. That being said, we'd have to speak with our colleagues as to whether there are other examples of general fund appropriations in the budget for projects or services outside of the health area for local purposes.
Assemblywoman.
Right. This issue came to us, and we're prepared to hold it over and in terms of discussion with it, to look into it more, because we also have the similar concern. We know there's a great need in that community. At some point, we thought, as we looked at some of the proposal with regards to the funding of undocumented, that this might also alleviate this problem and may get folded into it as well, this and the RFK proposal. I do have ongoing concerns of us constantly funding something temporarily, supposedly, without a solution to the problem. And that's one of the challenges. We thought we had helped last year to prevent the closure, and it didn't, and it's still closed. And so we have this proposal here now, so we're still looking into it. So we'll continue to, hopefully in the next few days, get additional information about it. But it's a part of a larger health package that we're prepared to hold over, and we'll look into it some more. We know there's a need, and I don't know if there's a precedent for us doing this before.
Senator Nielsen.
Proceed here, we've got to find some answers to what's going to fix it. Obviously, $3 million did not. And I'm not willing to just throw the money out there. We need a plan from some particular facility that says, yes, this is the answer, this is how it will be provided, and some accountability. Just throwing $3 million out doesn't make any sense at all. It did not work a year ago.
Thank you, Senator. So this will be kept open.
And we do not support the augmentation.
Thank you. Page 9 is with regard to Medi-Cal caseload and the impact of the President's executive order on immigration. And the Senate approved the governor's proposal, and the Assembly adopted the LAO assumption of a 24-month phase-in. Ms. DG, you want to, or is it Mr. Newton going to talk to us about the 24-month phase-in?
Yes, we find that the administration's assumption of a 12-month phase-in period for enrollment into Medi-Cal once the executive actions are able to be implemented is not consistent with historic phase-in periods for implementation. For example, in the existing DACA program, implementation of the magnitude that they're assuming took 24 months. So we recommended savings, which the Assembly adopted based on a 24-month phase-in period. We would also note that there's quite a bit of uncertainty giving litigation as to if and when the actions will be able to be implemented, although it's possible they will be implemented in the budget year.
And I would imagine that last week's court decision only backs up your timeline.
Right, continues the uncertainty as to if and when these actions can be implemented.
Very good. Senator Lara?
Yes, thank you. I just want to give kudos to the governor and the administration for including this money in the May revise to provide the medical coverage for qualified immigrants. And I think also the uncertainty of what's happening at the court behooves us to look at the Assembly version. I think it makes sense.
All right, so we do have a motion to take the Assembly version, and that would be 2-1 on the Senate side and 2-1 on the Assembly side for the Assembly version.
And we would just note that we agree as well that there is significant uncertainty, but any savings from the administration's version are really just one-time in nature because the full year ramp-up costs are still the same.
I'm going to pocket them nonetheless. Thank you. Page 10, drug billing. The Assembly has the proposal this time. Mr. Sue? Got you running back and forth.
Yes, thank you. The Assembly has proposed changing billing procedures for drugs and supplies dispensed by certain clinics by requiring the clinical dispensing fee to be the difference between what is known as the actual acquisition cost of a drug and the Medi-Cal reimbursement rate. And it removes the existing maximum dispensing fee caps in current law.
And currently it's whichever is lesser than?
Yes, there's two tiers involved in the current billing and reimbursement system. What is billed is the lesser of the facility's usual charge and the cost of the drug, and what is reimbursed is limited to the lesser of the Medi-Cal reimbursement rate and what is billed.
So the concern that we're hearing from these clinics is first, I would imagine first and foremost, the difficulty of working out all these differences. I'm sure there's a lot of time of investment and resources and frustration in trying to get some clarity. And then additionally, there would be some cost by making this decision.
Yes, Mr. Chair. It's our understanding from the proponents of this proposal that they see it mainly as an issue as moving towards a way to simplify the current billing and reimbursement system. They claim that the issue is really about it being quite unpredictable and costly to financially manage their resources. That being said, that you're right that one anticipated result in moving to this simplification proposal would be that the reimbursement from Medi-Cal for at least a small subset of these drugs would probably go up.
So just speaking hypothetically here, it is conceivable that we could deal with the simplification issue, but not incur the higher cost.
I would say that could be an option. We haven't looked into it in depth. They view the simplification as basically setting the Medi-Cal reimbursement rate as a default of sorts, and because that serves as a default, none of the costs of the drugs being dispensed would go down, but some would go up.
Very good.
We
Ms. Bosler.
see this in a general category of rate increases for a very, we think, a specific subset of pharmaceuticals. However, we haven't seen the language, and we would be concerned that $6 million general fund would be far too low if this methodology was expanded to other types of pharmaceuticals. So we do not support this methodology change.
And Mr. Sue, if we were to go with the Assembly simplification and also the improvement of rates for the providers, for the clinics, would there be any improvement in access or any additional benefits?
That's a very good question, and it's a difficult one for us to answer just based off of the limited information available. In our conversation with the clinic affiliates that are supporting this proposal, they said, again, that the main problem is really one of cash flow and it resulting in some serious financial problems for some individual clinics due to some amounts of Medi-Cal payments being held up, increased admin expenses from having to hire extra staff to deal with the complex billing issues. So in the worst case scenario, if these financial problems are severe enough for one clinic to have to reduce its operating hours or even shut down altogether, then conceivably it could affect access for the patients that visit those clinics. Now, the clinics, when they spoke with us, gave us two examples of some recent closures. A small facility in rural Northern California that served about 10,000 patients annually, and a larger one in the Bay Area that served 50,000 patients. And there they cited the billing and reimbursement issues as being one of the contributing factors to the closures. It's also our understanding that at least some of the patients from these facilities that shut down were diverted to or absorbed to nearby clinics that remained open. but we can't definitively say whether there was capacity there at the clinics to absorb all the additional patient load.
Okay, that is of concern to me. Again, on the Senate side, hardly insensitive to the issue at hand, but if we're going to have limited resources to begin any kind of reinvestments, want to make sure that we're doing it where it's needed most. But you're making a case that from your conversations with some of these clinics, that there is risk of access.
Potentially and conceivably, yes, if things got so bad that a clinic would have to completely go under, for instance.
Right. And I know Senator Allen has a bill, SB 447, which attends to this. Any other comments? I suspect we're going to keep this open for now.
We'll keep this open. This is an important issue. Like so many of the other health issues, we'll continue to keep it open. It's not the biggest issue, obviously, but it is an issue about resources and access, in terms of clinics being able to function and having a simpler process in terms of billing. Yeah, thank you.
Right. Senator Nielsen.
To the analyst, as we proceed with this open item, if you'd be so kind as to give critical scrutiny whatever information you got in from the clinics. Don't just accept what they say. If you could look into the information a little bit to see if there's credence to what they've submitted to you.
Absolutely, Senator. And we did ask them specifically which clinic shut down and what the patient census was at, and we verified it through independently looking to see that, yes, there was documented information about those clinics actually having to close their operations. So we take that very seriously.
You might just give us some bullet points on what those points were then, okay?
Absolutely.
Good point, Senator Nielsen. Thank you, Mr. Sue. Yes, Ms. Bosler.
We're not aware of any access issues. That this is the methodology that's in place is a common methodology in this world, and we're not aware of any access issues related to it.
Short of the access issues, are you sensitive at all to the need for simplification?
Simplification, it doesn't, so that was the first that I had heard it described as a simplification. I think that it really seems to be a shifting of risk. So I think that we would be concerned with a methodology change in the vein of what's been proposed here, but we're always interested in simplification because a lot of admin goes into complex reimbursement formulas, and so if that's something that that's definitely a tenet that we would be interested in furthering, but I think what's proposed here we have significant concerns about.
Do you think you could, given that you are sensitive to additional administrative costs and efforts, anything you can provide to us that might be another way to go about this, which doesn't change the cost structure to the state?
I would have to get back to you on that.
Okay. All right. So we'll be leaving that open. Page 11 is Caregiver Resources Centers. And the Assembly has the proposal here. LAO.
Sean Martin with the Legislative Analyst's Office. The Assembly proposal is $3.8 million general fund and additional funding for caregiver resources centers. These centers provide low-cost or free services such as referrals, care planning, respite care, counseling, education, and legal consultation to caregivers. Funding for these centers was cut in 2009 due to the state's fiscal situation. The centers currently receive $3.4 million general fund.
So this time the ball's in the Senate's court with regard to matters of priority and limited resources. This is mostly family caregivers, Mr. Martin?
Yes, it is. Our understanding is that the resource centers provide counseling to family caregivers, such as teaching them how to care for someone who has Parkinson's disease, for example, or Alzheimer's. Also, we'll give them legal counseling. For example, they might need to set up a conservatorship or a trust for the person who's suffering from the disease. And they also provide a range of other services.
And in the honored fashion of LAO finding compromises, is there one to be found here? Or just a matter of scale? Or could this be scaled?
This is scalable. So, for example, the budget in 2009-10 was $10.5 million, and it's been cut by over 70%. So we're down to $3.4 million general fund now, but you could potentially add more funding to it, less or more than the amount that the Assembly is proposing.
So the Assembly proposal would actually double the amount of general fund support. We could do anything up to that.
Roughly, yeah.
All right. We'll be keeping this item open as well. Page 12 is the naloxone grant program. The Assembly again has the proposal here. Ms. Deege.
The Assembly approved funding for a new naloxone grant program. The program would provide naloxone kits to nonprofits and government entities. Naloxone is an overdose reversal medication.
So can you talk to us a little bit about the federal approval of the drug Medi-Cal waiver? This will potentially free up some funds that could be used for this purpose at the county level?
Yes, so naloxone is a part of our drug Medi-Cal waiver that we talked about a few pages ago that's currently still being reviewed by CMS. But the provision of this drug is part of that waiver, and it is a covered Medi-Cal drug. So we don't support the separate grant program because it's already really built in to the system that we're currently implementing as soon as we get that federal approval.
All right. Assemblyman Bloom.
I'd just like to point out that there's a study out of UC San Diego that estimates that an investment like this could save upwards of 800 lives. This implements, if we were to do it, a model that has been used in other states successfully, and I think it's a pretty important initiative.
Thank you. And
I was going to ask, are you speaking in terms of it being on our list in terms of approved drugs, a drug that would be approved for, because we're looking at emergency individuals carrying it, persons having access to it, our police officers, firefighters, so you're saying this would be accessible to them through Med?
No, I think through the Medi-Cal program that the managed care plans are required to reimburse providers for substance use treatments, which include the provision of this drug. This grant program seems to be broader than Medi-Cal, so it would go to perhaps family or friends or emergency providers, depending on how the grant program is structured. So this would be broader than Medi-Cal.
Right, because I think the success of this drug lies in the fact that people have immediate access to it, not after they get to the hospital, but before. And I know in San Diego, UCSD has done the research, but also it's such an important piece in San Diego that our sheriff has invested in this drug to give to all of his officers because they realize their ability to administer it as quickly as possible saves the lives of hundreds of young people. And so he was bold enough to use his own budget to purchase this because it's just that important. So if it turns out to be that, yeah, it's one of the Medi-Cal drugs, if somebody comes in, you can administer it, fine. But at the same time, if it becomes a situation where we're talking about people, family members who have children or young adults who are involved in drugs and could easily administer this to them very quickly, our police officer, firefighters having access to it, then it's extremely important. So I don't think anyone questions the effectiveness of the drug. It has been proven over and over to be very effective. And as we start dealing with these issues, it has untold benefits, particularly in healthcare, with folks not having to go to the hospital and spending a lot of time on various machines and then eventually dying after all of that as well. But it definitely cuts the costs in terms of emergency rooms and emergency care. For this amount of money, the $2 million is really minuscule in comparison to the cost of a person who has OD, not only their life, but more importantly, if they remain alive for a period of time, the cost of emergency care is enormous.
So, and I would agree, we all recognize the beneficial aspects of the naloxone drug itself. The point being with regard specifically to the federal approval of the drug Medi-Cal waiver, that it will allow state and federal funds to be used for residential treatment services, and those residential treatment services are currently paid for with county funds, and with federal substance abuse prevention and treatment block grant funds. Those funds could then be freed up since they'd be covered with the benefit of the waiver, which would then free up those monies at the county level rather than spent on residential treatment services, but for this purpose. So that was the thought of our subcommittee.
We also make an assumption that our counties would do it, and that's the ongoing challenge, I think. You have varying services at counties. Our county sheriff did it on his own. I doubt if our county board would have done it. I mean, given the disparity sometimes in the care between counties. So if it's important enough and it reduces various costs, I'm not sure if we want to say to counties, now that you have money, you have the flexibility to do it, because every county doesn't do it. Don't have the same level of commitment if we really believe that this is something that we should do. So we're prepared to hold it over, but I would not want it to be totally dependent upon the counties finding the resources to do something that we think is important, if we think it's important enough to do. Clearly that we will find a tremendous disparity between services being offered in certain communities versus some others where people may be much more critical of drug addiction, more critical of drug overdose, and not as willing to invest in rescuing lives as some other counties might. We see that disparity often.
I cannot argue that, Assemblywoman. Well stated, thank you. Page 13, Mr. Mipp. Mr. Martin?
Thank you. The governor proposed language to modify the Mr. MIP program and to extend the period of time to reconcile payments for the guaranteed issue pilot program for 6 to 18 months. Both houses rejected the proposal to modify Mr. MIP. The Senate adopted trailer bill language to extend the period of time to reconcile payments from 6 to 18 months, while the Assembly rejected that trailer bill language.
Thank you, Mr. Martin. And Ms. Bosler, could you tell us a bit more about your proposal to modify Mr. MIP that we both rejected?
Yes, the approach on the Mr. MIP program, which was really something that was a gap coverage program that we had before healthcare reform was implemented, when healthcare plans were able to routinely deny coverage to people that had serious pre-existing conditions or serious health issues. So this program was sort of a safety net for those individuals. Since the new law of the land is that coverage shall be provided regardless of conditions, our approach has been to slowly move away from these specialty targeted programs and move those individuals into comprehensive health care coverage, whether it be Medi-Cal, if the income level allows, or Covered California. So that was really the underpinning of our proposal in January. There's also an issue with the Guaranteed Issue Program, which is for the graduates, the people that move out of Mr. MIP, and needing extended period to reconcile payments to health plans. And the Senate adopted that portion of the language, and we definitely support and think we need that language in order to make sure the state recovers costs of this program. Just another little note, this program is not a shared cost with the federal government. This is a state-only funded program. The monies that support it currently are Prop 99 monies, and then also the Admin Fines and Penalties Fund. So we do support the Senate's action. We do want to continue to work on modifying the program and moving individuals that are eligible into the comprehensive health care. There are some unique populations in this program, including those individuals with end-stage renal disease, that currently the federal government has some prohibitions on Medicare Advantage plans for those individuals. This is a declining population in this program. We're now actually only about 2,000 individuals are in this program, and I saw the caseload last night, and it's been steadily declining over time.
Mostly end-stage renal failure?
I don't have all of the information about the portion of the remaining population that has that specific disorder, but my understanding that is one of the groups that continues to be in the program because of this federal carve-out related to Medicare Advantage plans.
Okay. Assemblywoman Weber.
Mr. Chair, we move this. We'll accept the Senate language.
Very good. So that will be 2 or 3 on the Senate side, 3-0 on the Senate,
3-0 on this.
3-0 on the Assembly for the Senate version. Moving on to county administration funding. Ms. DG.
The governor proposed to increase Medi-Cal county administrative funding by $150 million, of which $48.8 million is general fund. Both houses approved the governor's proposal and augmented county administration funding by $95.3 million, of which $31 million was general fund. However, the Assembly also adopted budget bill language allowing the Department of Finance to augment county eligibility funding during the budget year if additional savings are identified with notification to the JLBC.
Thank you, Ms. DG. So this is the difference between the houses being the budget bill language, which is in fact merely permissive, and I suspect that, Ms. Boswell, you're going to tell us that this authority already exists.
Yes, that's right. We have provisional language right now to move money between schedules in the budget bill, and so we would view this as just unnecessary.
And Ms. DG, do you think that the budget bill language is either beneficial or necessary?
No, we don't find that the budget bill language is necessary, and we would also note that it would create a situation where the funding automatically was given to counties for Medi-Cal administrative purposes, whereas otherwise, if it was not spent, it would eventually revert to the general fund, which may provide the legislature with more flexibility for how to use those funds. And as the Department of Finance stated, counties can already be given additional funding for Medi-Cal administrative costs as needed in the budget year.
Our interest in this, of course, is the fact that I think there's basically both the proposals are very similar. Our difference is that in the Assembly, we adopted a budget language that would allow additional funding to be identified and provided to counties if additional savings are identified. We wanted to keep this language in there in order to make sure that that they continue, the Department of Finance and others continue to look for the $17 million that we believe is still there. Obviously, if it's not, it's not, but clearly this provides a motivation for the continue to look for these $17 million in savings and put it into play.
Finance, where's the 17 million?
We're not aware of the 17 million. After our May revision was put to bed, there was the identification of this additional 33 million, and given the important role that the counties play in really running the Medi-Cal eligibility system on behalf of the state, we are supportive of those additional resources. We are working very hard at the Cal HERES table to improve the functionality of the system, but as many of you know who have worked on implementation of complicated information technology programs, there are a lot of steps that have to be taken in order to make the system really work the way it was intended.
So minimally, if this is suspenders onto belts and permissive and only if additional funds are identified, what's the risk here? Not much.
I don't think it's a matter of harm.
All right, Senator Lara. Okay, we have a motion for the Assembly version, 2-1 on the Senate side, and 2-1 on the Assembly side for the Assembly version.